Diagnosis of diabetes mellitus type 1. Diabetes mellitus is characterized by recurrent or persistent hyperglycemia, and is diagnosed by demonstrating any one of the following. Fasting plasma glucose level at or above 7.0 mol/L, 126 mg/dL. Plasma glucose at or above 11.1 mol/L, 200 mg/dL, 2 hours after a 75 grams oral glucose load as in a glucose tolerance test. Symptoms of hyperglycemia and casual plasma glucose at or above 11.1 mol/L, 200 mg/dL. Glycated hemoglobin, hemoglobin A1c, at or above 48 mol/mol, greater than or equal to 6.5 DCCT%. This criterion was recommended by the American Diabetes Association in 2010, although it has yet to be adopted by the WHO. About a quarter of people with new type 1 diabetes have developed some degree of diabetic ketoacidosis, a type of metabolic acidosis which is caused by high concentrations of ketone bodies, formed by the breakdown of fatty acids and the deamination of amino acids, by the time the diabetes is recognized. The diagnosis of other types of diabetes is usually made in other ways. These include ordinary health screening, detection of hyperglycemia during other medical investigations, and secondary symptoms such as vision changes or unexplained fatigue. Diabetes is often detected when a person suffers a problem that may be caused by diabetes, such as a heart attack, stroke, neuropathy, poor wound healing or a foot ulcer, certain eye problems, certain fungal infections, or delivering a baby with macrosomia or hypoglycemia, low blood sugar. A positive result, in the absence of unequivocal hyperglycemia, should be confirmed by a repeat of any of the above listed methods on a different day. Most physicians prefer to measure a fasting glucose level because of the ease of measurement and the considerable time commitment of formal glucose tolerance testing, which takes 2 hours to complete and offers no prognostic advantage over the fasting test. According to the current definition, 2 fasting glucose measurements above 126 mg/dL, 7.0 mol/L, is considered diagnostic for diabetes mellitus. In type 1, pancreatic beta cells in the islets of Langerhans are destroyed, decreasing endogenous insulin production. This distinguishes type 1's origin from type 2. Type 2 diabetes is characterized by insulin resistance, while type 1 diabetes is characterized by insulin deficiency, generally without insulin resistance. Another hallmark of type 1 diabetes is islet autoreactivity, which is generally measured by the presence of autoantibodies directed towards the beta cells. Autoantibodies. The appearance of diabetes-related autoantibodies has been shown to be able to predict the appearance of diabetes type 1 before any hyperglycemia arises, the main ones being islet cell autoantibodies, insulin autoantibodies, autoantibodies targeting the 65-keta isoform of glutamic acid decarboxylase, GAD, autoantibodies targeting the phosphatase-related IA2 molecule, and zinc transporter autoantibodies, ZNT8. By definition, the diagnosis of diabetes type 1 can be made first at the appearance of clinical symptoms and/or signs, but the emergence of autoantibodies may itself be termed latent autoimmune diabetes. Not everyone with autoantibodies progresses to diabetes type 1, but the risk increases with the number of antibody types, with 3 to 4 antibody types giving a risk of progressing to diabetes type 1 of 60% to 100%. The time interval from emergence of autoantibodies to clinically diagnosable diabetes can be a few months in infants and young children, but in some people it may take years, in some cases more than 10 years. Islet cell autoantibodies are detected by conventional immunofluorescence, while the rest are measured with specific radio-binding assays. Type 1 diabetes prevention. Type 1 diabetes is not currently preventable. Some researchers believe it might be prevented at the latent autoimmune stage, before it starts destroying beta cells. Immunosuppressive drugs. Cyclosporin A, an immunosuppressive agent, has apparently halted destruction of beta cells, on the basis of reduced insulin usage, but its kidney toxicity and other side effects make it highly inappropriate for long-term use. Anti-CD3 antibodies, including teplizumab and atlixizumab, had suggested evidence of preserving insulin production, as evidenced by sustained C-peptide production, in newly diagnosed type 1 diabetes patients. A probable mechanism of this effect was believed to be preservation of regulatory T cells that suppress activation of the immune system and thereby maintain immune system homeostasis and tolerance to self-antigens. The duration of the effect is still unknown, however. In 2011, Phase 3 studies with atlixizumab and teplizumab both failed to show clinical efficacy, potentially due to an insufficient dosing schedule. An anti-CD20 antibody, rituximab, inhibits B cells and has been shown to provoke C-peptide responses 3 months after diagnosis of type 1 diabetes, but long-term effects of this have not been reported. Diet. Some research has suggested breastfeeding decreases the risk in later life, and early introduction of gluten-containing cereals in the diet increases the risk of developing islet cell autoantibodies. Various other nutritional risk factors are being studied, but no firm evidence has been found. Giving children 2000 IU of vitamin D daily during their first year of life is associated with reduced risk of type 1 diabetes, though the causal relationship is obscure. Children with antibodies to beta cell proteins, i.e. at early stages of an immune reaction to them, but no overt diabetes, and treated with niacinamide, vitamin B3, had less than half the diabetes onset incidence in a 7-year time span than did the general population, and an even lower incidence relative to those with antibodies as above, but who received no niacinamide. People with type 1 diabetes and undiagnosed celiac disease have worse glycemic control and a higher prevalence of nephropathy and retinopathy. Gluten-free diet, when performed strictly, improves diabetes symptoms and appears to have a protective effect against developing long-term complications. Nevertheless, dietary management of both these diseases is challenging, and these patients have poor compliance of the diet.